observation, 12-month observation. So we call that child fulfilling the criteria of short stature. So the most important thing is the causes. So causes of short stature, proportionate short stature. What do you understand by this terminology, proportionate short stature? Anybody? If we are going to make it interactive session, then you all will enjoy. Is my voice clear? So nobody. Proportionate short stature, it can be a normal variant. So there are two conditions which comes under normal short stature, which is the top of it is familial short stature and constitutional growth delay. So what do you understand by these two? What is the difference? A boy is coming to you, a 10-year-old boy with the short stature. So what do you ask from the parents? If you are suspecting familial, definitely family history. And constitutional, what do you ask? Important question in history about the family history of delayed puberty. Okay, so the prenatal causes, intrauterine growth restrictions, the placental causes like teratogens, vascular abnormality in the placenta, and the intrauterine infections like torch infections, and some genetic disorder like chromosomal and metabolic disorders. So any common chromosomal abnormalities, can you name? Like Down syndrome, like Edwards syndrome, and some other chromosomal metabolic disorders. Postnatal causes undernutrition, which is very important in our community, in our country. So the undernutrition and the chronic systemic illness. What would you ask if you are suspecting that this short stature is because of the malnutrition? Definitely dietary history and the balanced diet also, because sometimes there is decreased protein content, some food allergies also, and some chronic systemic illnesses like congenital heart disease, chronic asthma, cystic fibrosis, renal tubular acidosis, they all present with short height, and steroid dependent nephrotic syndrome, some malabsorptive syndromes like inflammatory bowel disease and chronic liver diseases, chronic severe infections like TB and pertussis. They both can lead to the chronic infection, and hematological diseases like thalassemia, sickle cell anemia. So there are very long list of these chronic systemic illnesses. Psychosocial short stature like emotional deprivation, some endocrine causes, as you all know that the growth hormone deficiency, insensitivity, hypothyroidism, diabetes mellitus, Cushing syndrome, pseudo hypoparathyroidism, some pubertal delay, precocious puberty, they all present with short stature. So what is the basic difference in between the endocrine causes and chronic systemic illnesses? What is the basic difference? As we can if we all just remind ourselves what happened in case of Cushing syndrome and hypothyroidism, the child become short and obese. So in case of growth hormone even, and some syndromic phases also. So the endocrine causes would lead to short stature, but weight would be more or even normal. But in case of chronic systemic illness, the child would be lean and thin, emaciated, malnourished, along with short stature. So both components, the weight and height, both are involved in chronic systemic, but weight is increased in case of endocrine causes. Disproportionate short stature, it is also important. Uh, if we talk about your exam scenario, your clinical stations. So disproportionate means the proportion of the upper part of the body and the lower part, it is not equal. So sometimes the trunk is short, sometimes the limbs are short. So with short limbs, the most important one is achondroplasia, hypochondroplasia, chondrodysplastic, some syndromes, ectodermal dysplasias, and metaphyseal chondroplasias. They are very, there's a big list, but in short, you can say that achondroplasia and some dysplasias, skeletal dysplasias in collective term. Deformities due to the osteogenesis imperfecta, as you all know that in osteogenesis imperfecta, repeated fractures, recurrent fractures takes place, and the fracture heal with a scar tissue with callus formation, and there are so many bony deformities because of the recurrent fractures. So the height and the limbs become short because of these growth disturbances and deformities. Rickets. Rickets is also very important in peds. Refractory rickets, some inherited varieties of rickets, they are also present with the bowing of legs and the short limbs. So ricket is also very important to keep in disproportionate with short limbs and hypothyroidism. With short trunk is some dysplasias. The most important one is mucopolysaccharidosis, Klippel field syndromes. The only thing you can remember is the problems lead to scoliosis, kyphoscoliosis. They make the trunk short. So they are associated with the short trunk, short stature. So one of the most important example and very commonly seen is mucopolysaccharidosis and the problems which will lead to the scoliosis, kyphoscoliosis. Okay, so it is a model like we have to remember the infancy, childhood, and puberty. So the stature and the growth velocity, it is highly dependent on nutrition in infancy. So if the nutrition would be faltering or the child would be malnourished, so it will lead to short stature in infancy. So basically in the time period of first year of life, the growth is totally dependent on the balanced nutrition, balanced diet. And in childhood, these are some endocrine causes like hypothyroidism, growth hormone deficiencies. So it's just to keep in our mind about the general presentations. In infancy, the most important to inquire about the nutrition. In childhood, about the hormonal problems. And in puberty, disorder of puberty, delay pubertal growth because of some systemic disorders, some precocious puberty. You have to ask in history. So this is the same as we have discussed in previous slide. Investigation. The most important is to how to investigate. First of all, in any management, the initial start is from history. So what history would you like to ask? Anybody? You will ask about the growth velocity and if the child is following the growth velocity or it is sudden. We will ask about definitely the systemic signs and symptoms which can lead to the short stature, faltering growth, and some hormonal like growth hormones. We can ask about the uh, uh, genitalia. Is any abnormality in genitalia, we can also examine the child. And in case of social history about the socioeconomic status, living conditions, overcrowding, we can ask. They all are very important. So the most important and the most 80% is going to give us lead us towards the diagnosis is history. So accurate measurement of child and his parents. So first of all, history, then examination. In examination, measurement is very, very important. And The other examination like the blood pressure, the vitals, and the head to toe examination start from the head and fundus, visual fields, Tanner staging very important, and the clinical examination they are also very important like abdominal examination, CVS, TNS examination, spine examination, and there are some important maneuvers which we will discuss later. Bone age. What is the significance of the bone age? Bone age of wrist, if it is equal to the chronological age, what does it indicate? If the bone age is equals to the chronological age, it means it is the child does not have the potential. It means it is more, going under the category of familial short stature. And if it is less than delay bone age, then it is in favor of constitutional. So basically, boys usually present with constitutional growth delay. If the bone age is advanced, what does it indicate? It indicates any hormonal problem. There are two hormones which causes the advancement of the bone age: androgens and thyroxine. So if we see the advanced bone age, we have to think about the thyroid, hypothyroidism, and the androgens axis, like the precocious puberty. Karyotyping in girls, a syndrome which presented with short girls. The most important one. Can anybody name? Can anybody name a short girl syndrome? Turner syndrome. And specific investigation which we are going to be lead by our history and examination. History of IUGR, IUGR asphyxia toxins, if journal history, chronic debilitating disease. This again start with the history, growth history, height and weight charts, growth velocity is very important. So if anybody asks you what would you like to see the in growth charts, so you have to reply like I would like to check the growth velocity. Family history, parental stature, mid-parental height, and pubertal patterns of parents. So this is important history which is correlating our diagnosis. The history of delayed puberty in parents, as we have discussed, it will lead to the etiology would be the constitutional delay of growth, low birth weight, SDA, or IUGR also. Neonatal hypoglycemia, jaundice, and the micropenis, it is leading towards the growth hormone deficiency. Dietary intake, the most important is undernutrition, malnutrition. If the diet caloric count is deficient and the balanced diet and there is no balanced diet, headache, vomiting, and the visual problems, some pituitary problem or any space occupying lesion in head, and lethargy, constipation, and weight gain, hypothyroidism, polyuria, chronic renal failure, and renal tubular acidosis. Social history is psychosocial dwarfism. Examination. So what is your part to do is to take a very good history and examination. So observation, what do you observe by just looking journal impression? Definitely, you are going to, by doing initial inspection, the um, height observation and the growth patterns. Excuse me. observation of the growth and growth like stature and weight. Uh, how would you just think if this child is short or normal without measuring? Anybody has any idea? It is a very vague just observation. If you mark on your body, like for example, the lower trunk at the level of your just thigh, uh, at the level of the thigh, that how much centimeter it is, and then you just make a demarcation line and compare that with the child. So it is a very crude method to observe is the child short or normal, and about the weight also. Is the child normal weight or malnourished? Measurements are very important. Maneuvers and relevant examination. So measurement, the most important is height. How we can take height, we will discuss, and weight, OFC up to the age of 2 years, sitting height. So sitting height is also important. It will give us the idea about the upper trunk, upper segment, arm span, lower segment. So we will take the sitting height and then we minus it from the total height. So we will get the lower segment. The skin pore thickness. It is, if you are suspecting it is secondary to the malnutrition, you can take it. If it is relevant, then take it. Calculate the upper segment and the lower segment ratio, mid-parental height, and estimated adult height, height velocity. Plot on appropriate growth charts. Okay, so how we can measure the height? It is without footwear, heel back touching the wall, and lower border of the eye socket in same horizontal as external auditory meatus. So looking straight ahead, a right angle block slide down your touches the head. So it in very simple words, all the the head, shoulder, gluteal region, and the heels all should touching um, the wall. Okay, so the correction for the mid-parental height, male height, this is the formula. Mother height and father height plus 13 divided by, this is for the boys. So this formula is not used nowadays because of the growth charts. There are growth charts for the parents' height also. So you just keep this formula in your mind if anybody asks you. For the girls, it is the mother height plus father minus 13 divided by 2. So this is the formula. You should have the idea about this formula. Otherwise, nowadays the growth charts of the parent site are available. You can plot and then compare. This is a normal CDC growth chart. So height velocity of boy grows from 119 to 122 centimeter from 99.5 years. So it is usually, he has grown 3 centimeter in half year. So annual growth velocity would be, this is the formula, 3 divided by half. It's 6 centimeter annual growth velocity. So it is in between 75th and 95th percentile. These are some complex calculations. Just monitor on the growth charts and compare it with the previous height. So you have to ask about the previous centile charts to plot it. What was the height 1 year before or 6 months before, and then plot all together at the same growth chart. If it is linear, then it is normal. This is another very complex, just leave it. So this is the velocity chart. Then it was at the 25th centile and then it increases. Okay. The important is the proportion. Now look at the proportion. Is the child disproportionate or proportionate? If you think that this is a disproportionate, then it is very important to take the sitting height and standing height. Standing height minus sitting height will get the lower segment. So we have to calculate the subaxial leg length. It is very easy to just take the sitting height, uh, make the child sit without cross legs. The gluteal region should touch the wall, and take the sitting height. This is another growth chart. It's showing that it is linear growth. It is the difference between the subaxial leg length. Leave this subaxial leg length. Look for the clinical clues. Weight, weight, age more than the height, age, short and fat. As we have discussed, short and fat is endocrine, and high more than the weight, but both below the chronological, it is undernutrition. So the undernutrition is thin and short. These are the clues. Midline defect, it's the growth hormone deficiency. Rickets can be associated with renal failure, some renal pathologies like renal tubular acidosis, rickets, hypophosphatemic rickets, and malabsorption. Pilar, renal failure again, and nutritional anemia, malnutrition, malabsorption, celiac, cystic fibrosis, and malnutrition secondary, primary also. Secondary to poor intake, poverty, social factors also. Obesity, it is indicating towards some endocrine problem as we have discussed in our previous slides like hypothyroidism, Cushing syndrome, Prader-Willi syndrome, metacarpal shortening, Turner and pseudohypoparathyroidism. Uh, this is very important clinical sign. Cardiac murmur, any congenital heart disease or Turner syndrome. Disproportionate, as we have discussed, like rickets, skeletal dysplasia, dysmorphism, congenital syndromes, hypertension, chronic renal failure, goiter, hypothyroidism, central obesity, and stria Cushing syndrome. So this is just the discrimination of the disproportionate, proportionate, and syndromes. So disproportionate would be either short legs or short trunk. So we have just discussed short legs in the important diseases, achondroplasia and NPS in short trunk. Proportionate IUGR sequelae, Russell-Silver syndrome, and so many others like as we have discussed in the chronic systemic illnesses, syndromes like Lunal, Standards, Downs. So some few important ones we should remember. Okay, the short child that looks normal, target height, calculate, not within target range. So watch for the growth velocity, normal growth velocity or low growth velocity. So if the growth velocity is low, then there is some problem going on like any systemic diseases, genetic, chromosomal, endocrine disorders. If it is within target, then just observe and reassure. These are the important maneuvers. So first, what maneuvers are you going to perform? First, stand straight like attention. So you would see the hands are touching the mid thighs, and then arm span. Arm span is also very important. Hands together for any asymmetry. Some syndromes are associated with asymmetry of the body parts, like Russell Silver, and straight arms, to check for the cubitus valgus, carrying angle, which is increased in case of Turner and Nunans, thumb to shoulder. In E, you can see that thumb to shoulder, if it is undershooting, overshooting, or normal. Overshooting means the proximal segment of the hand is short, like the terminology we use is rhizomelia. It is associated with the achondroplasia. If it is mesomelia or acromelia. So some syndromes with the middle shortening and the acromelia is for the acromesomelic dysplasias. Palms up for the creases of the hands, and the dorsal aspect should also be observed. Inspect for the trident hand, which is very important clinical clue in case of achondroplasia. Make a fist to see the fourth metacarpal. If it is short, then it is going to give a depression while doing fisting of hands, and it is important for the pseudo-hypoparathyroidism and Turner syndrome. Okay, the back. Back is also important for what? Anybody have any idea? For the hairline, short neck, and any scoliosis. How can you comment on scoliosis? If the on bending forward, there is a curvature of the spine is deviated on one side, and any asymmetry of the hands and the distance of the hand and the trunk. Sit up and then bending forward. So by doing bending forward, you can comment on scoliosis. So the child is short and short for the family. What next? Is the child very much below the third centile or just below? If just below or within target range, then watch the growth velocity. If it's very much less than third centile, then investigate. So the level 1 investigation we all have discussed, the CBC, ESR, bone age, urine stool, blood. These are the important tests, baseline tests, according to the history. Bone age assessment should be done in all children with short stature. Bone age gives an idea as to what proportion of adult height has been achieved by the child and what is remaining. Bone age is delay compared to the chronological age in almost all causes of short stature except familial and precocious puberty. Familial, what would be the bone age? It's equal to the chronological age, and in precocious puberty, as we have discussed, the bone age would be advanced because of the androgens. These are the tier 2 investigation. Karyotyping is mandatory if a short girl comes to you. So the important investigation in all girls, short girls, is karyotyping. This is type 3, celiac, duodenal biopsy, growth hormone stimulation test, MRI. Management. Any idea about management? Anybody? Counseling of the parents, it is the most important. For the physiological causes, even for the pathological causes, counseling play a very major role in good management. Dietary advice, any specific diet for the celiac disease, renal tubular acidosis, undernutrition, a balanced diet plan should be handed over to patient. Limb lengthening procedure, this is This uh, this is for the scoliosis, not limb lengthening. If there is a scoliosis, then there's some orthopedic surgeries if they can play a role, but it comes uh, at the end, and then it depends what is the cause. If hypothyroidism, then thyroxine. If growth hormone deficiency, then growth hormone. If CRF patient, then the management of CRF. Monitoring of height is mandatory for good outcome in any form of therapy. These are some pictorials, uh, pictures which can help you just do the spot diagnosis. The important thing is micropenis in this picture and cryptorchidism. I'm just showing you the pictures. It's very detailed. This is hypothyroidism. So, child is dull, sleepy, may present with the umbilical hernia, poor feeding, poor facial features, dry skin. This is pseudohypoparathyroidism, obesity, as we have discussed in endocrine causes, short and obese, short fourth and fifth metacarpals, which we are going to examine in maneuvers, delayed puberty in girls, this is Turner, Chalmans. In girls, the Turner is the most important one to consider. This is Cushing. These are some pictures which are going to help you to make a spot diagnosis. And then psychosocial dwarfism. I think that's an SG infants, achondroplasia. This is very important. You can appreciate the short limbs, the limbs. If he straight his arms, so the upper one third, his arm would reach till the upper one third, not the middle of the thighs. It is very important to make a spot diagnosis. This is rickets, some inherited variety of rickets. What is the risk factor to develop rickets, which is visible in this girl? Anybody can reply? Any intelligent one? A very intelligent one will answer this question. Anybody? Yes. What is the risk of developing rickets in this girl? Rickets, vitamin D को और क्या कहते हैं? What is the alternate name of the vitamin D? शायद कहीं लिखा हुआ भी हो यहाँ पे. Sunshine vitamin. So the risk is dark skin, which is very much obvious. Okay. Dark skin person. This is Prader-Willi. It comes in workup of obesity. This is Russell Silver.